Before moving to the Q&A, I would like to let you know that it's our great honor to have Professor Junji Kim with us today. Professor Junji Kim is one of the most famous surgeons in laparoscopic colorectal surgery. He had many students in Thailand and in Southeast Asia. Thank you, Professor Junji Kim. Okay. Are we ready for question and answer? Now we got the 6th question. For 5 questions from our friend Joseph from Manila. He asked directly to Dr. Songpon. I would ask Dr. Songpon to answer his questions. Songpon, please.
Thank you. Thank you, Joseph, for your questions. It's very interesting questions. Your first question asked me about the, do I routinely take the gastric branch of the GTC? I'm not. Usually I'm only cut the branch that supply from the colon only. But in some case, we have to do the resection of the gastroepithelial vein, the right gastroepithelial vein for the colonic mobilizations. And however, for the extended right colectomy, I always resect the gastrocolic trunk at the origin in order to mobilize the transverse mesocolon. Is that answer? Okay. And so your next question is the port placement. I usually use the standard port for the right colectomy. I never go between the legs. Maybe it's a good idea. Maybe next time I'm gonna try. Do you have any experience with the standing doing surgery, right colectomy between the legs? If it good, you can comment in the comments, and then I will try later. And for the splenic flexor cancer, you asked me that do I take the left branch of middle colic intracochlearly? Yeah, I usually do it intracochlearly. And for the next questions from Dr. Kamalet asked me that what's the technique and what's my recommendation for the approach of the middle colic route for the laparoscopic extended left hemicolectomy. So it's really very important questions, and actually it's depend. Long and short, it's depend because it's depends on the location of the tumor. If the tumor is go proximal and close to the middle colic origin, I'm gonna do extended right colectomy instead of the left colectomy or extended left colectomy, and then in that particular case, I usually cut the middle colic at the root. And for the splenic flexor cancer or descending cancer, I usually do the left colectomy. Like I like it the left branch of the middle left branch ascending left of the IMA branch, and then do the left branch of the middle colic instead. Is that answer your questions?
Okay, 2 more questions from Joseph go directly to Dr. Prapon. Dr. Prapon, could you please answer Dr. Joseph, please?
Thank you, Dr. Joseph, for the question. The first one is the port placement when I do the splenic flexor down. Okay. When I want to do the splenic flexor mobilization, I tend to use the left upper quadrant port for the right hand. But if it's not enough, I will add the one more port at the right upper quadrant and move to use it for the left hand. For the next question, about the choroidal anastomosis, do you also test it with a reverse airlift? Okay. If I do the hands-on choroidal anastomosis, I never do the airlift test. But if I make anastomosis with stapler, I always use the airlift test.
Okay, we just got a new question from Dr. Noptanai. He's the past president of Thai Colorectal Society. The question goes directly to Dr. Thitithep. Thitithep, please.
Thank you, Ajahn Noptanai, for the board exam question. I think I think the concept of CME, we should follow it in every cases, because there's evidence that doing the good CME and good quality CME specimen will guarantee the better survival for the patient. But the extended lymphadenectomy, like in CVL and in the D3 dissection, because many papers will show only their benefit, but they will less and less talking about the morbidity and the benefit gain in the extended lymphadenectomy or the D3 dissection. Also there are some benefit, but the real benefit, I mean the impact of the benefit gain, is not that high. There's one paper that calculate the impact of survival. I mean, they calculate the prevalence of metastasis and the survival benefit, and they show that the impact is low, quite low, comparing with the standard D2 dissection, but the morbidity is the same. So I think we have to choose to use this approach in selected patient, like in the patient that you see that there's the lymph node metastasis in pre-op imaging, or when you do the laparoscopy and you see the enlarged lymph node. I think those patients, you're going to be like forced to do it anyway. Is that answer your question?
Thank you, Thitithep. Dr. Songpon, I would like to ask you one question. From your video, sometimes you use the 31 with hook. Sometimes you use Pro Plus. I would like to hear the difference between these two instruments. Which one you prefer and why?
It's very good question. Thank you for the question, but it's very hard to answer, because today our section was sponsored by the COVID and guys. However, actually, I'm a big fan of the COVID, the Medtronic device, especially the 31 with hook. But however, recently I have to deal with many advanced cancer, huge tumor, like a T4 lesion that I have to do the multi-visceral resection, like do excentrations or like this case that the previous case that I showed you today, the T4 lesion for the right side or something. And that particular cases, they have very dense desmoplastic reactions, and sometimes we take surgery times very long. The problems, I have to say that the surgery one with hook, the ergonomic is very good. The suction things and the button and everything is very good. but the tip of the device is very fragile, and sometimes I have to change the device many times because of the tips breaking. The ProPlus itself, the ergonomic thing is maybe okay. However, the tips is very flexible and strong. So I think that's my question and my answer.
Any more question, please? On that, sorry.
Let me join the panel. Thank you very much. I have been very much enjoying the beautiful video from both of you, Songporn and Prapon, and also Tidite for the nice review. So at this point, before we step to the next, could I have invited Professor Junji Kim for some words? I know that as Jirawat has been already informed that here in Thailand, also in Asia and Southeast Asia specifically, most of us are having a train or has been giving opportunity to learn from you. Could you please give us some words for the improvement of the contribution from our area? Thank you, Prof. Junji Kim. I guess Prof still with us, but we'll see how he join us. Anyway, in the meantime, waiting for Prof. Junji Kim. So Songporn, thank you very much. You have shown to us a very beautiful video of doing the right side colon. You mentioned earlier that the right side colon might be, wrongly concluded that it's not too difficult, but to have it done clearly and nicely, I think that is it's very difficult. I have to have the skill and also the philosophy of doing the operation like what you have shown to us. Thank you very much. And also, Papon, beautiful. I never think that I can do something like that in the small area of pelvic. Thank you, congratulations. Any more question or any discussion from the panel? Would I also invite General Sudhajit and Professor Vitun for some discussion?
Yeah, I have some question to the colorectal team. In case of you face with T4B lesion, what is your strategy? Downsizing first and then go on laparoscopic surgery or open extensive surgery? To anyone in the team, can you hear me?
Okay, I would like to ask Dr. Songporn to answer this question first.
Thank you, Prof, for your interesting questions. It depends on what's the T4 lesions, where's the location of the tumor, especially if it's in the pelvis. We usually begin with the neoadjuvant treatment, either radiations, chemoradiations, or induction chemo, followed by the neoadjuvant chemoradiations, and or followed by the consolidation chemo. Because nowadays the treatment strategy for the rectal cancer is changed a lot, and then but however for the T4 lesion, for sure, for the rectal cancer, we're gonna do the neoadjuvant, some way of neoadjuvant treatment before surgery. After radiations or other kind of neoadjuvant treatment, we're gonna re-evaluate it, and usually we're gonna do the en bloc resection, like multi-visceral organ resection anyway. And now we also do the by laparoscopic surgery for the T4 lesions in rectal cancer too. We do a lot of laparoscopic extentration and do every week. for the laparoscopic excentrations or even sacrectomy. We can do by minimal invasive too. For the right side, if it's T4 and it is, for the colon, I think if it is T4, is kind of very different entity from the rectal cancer, because usually the colon is mobile, and then if it is T4, we usually can do the en bloc dissection for the colon anyway. And however, in some patients, I have trained to send the patient to get the neoadjuvant chemo first too. But we have to be careful of the response of the variety of the response of the neoadjuvant treatment in colon cancer too. It's kind of very controversy here for the colon. And however, we're gonna do the laparoscopic en bloc dissection anyway. We rarely do the open surgery. It's wrong. I still do the open surgery, but now we do open surgery less and less for the T4.
Dr. Prapon, we would like to hear your thoughts.
Hello? Can you hear me? Okay. For me, I think I have the way to practice like a Dr. Songkorn, because if we have to separate colon and rectum, and if the rectum is very locally advanced, I will always send patient to do the chemoradiation. Another one reason is my very long queue. So I have to send patient to do the CCRT first.
Now we got Prof. Junji Kim with us. Good afternoon, Prof. Kim. How you doing?
I'm okay.
Wonderful.
Good afternoon, all my friends. I enjoyed young surgeons' talk very much. And I saw a videotape. I'm surprised. Just looks like, especially the 31 technique, just like my own technique. I think, oh, that surgeons are me, not Thai young surgeon. I'm very surprised and congratulations. Dr. Jirawat, Professor Jirawat?
Yes, I'm here.
And Chuchip, you teach your young surgeon very well. I think you're a very good teacher.
Thank you very much, Prof.
Besides, I can say congratulations, and I enjoyed your young surgeons' good talk. Thank you very much for your webinar.
Thank you very much, Prof. Kim. We are very happy and we are honored to have you with us today. Thank you. This is all your, students here, so I think you should be proud of them. And I enjoy very much the talk.
Very proud of all Thai young surgeons. Thank you.
Thank you, my Prof. So I think, Prof. Jirawat, we may have some question or discussion. The session is very interesting, very successful. So I think we got one more question. Let's see what is that. Now I think it's going to Songpon again.
Yes, Songpon.
Maybe because I talk not that good, so there's too many questions for me.
No, you are super hot.
So, thank you, Joseph, for your another good question. It's very interesting for using the ICG nowadays. I not usually use the ICG for the routinely right colectomy dissections. However, when I was trained in US. I use it. My mentor George Chang, he used it once because of the that case. There's recurrent case. She's like 75 years old, females who got right hemicolectomy first, like 2 years ago, and then the nodes was frequent in the apical area. So at that time, we would use the ICG to identify the vascular structure because it's very hard to identify the post-operative dissection vascular structures because the vessel is going to be very distorted. And then I think we already published that paper last 2 months. We're using that the ICG to identify the nodes and also the vascular structures because we're going to do the D3 dissection for that case too. I think for the routinely use of ICG, I don't agree with that. But however, after let I say that scenario, maybe there's some roles of the ICG in some particular cases. If that can answer your questions.
Okay, thank you very much. Dr. Steph, I believe we have done with our job. We would like to pass it to you now.
Thank you very much. As mentioned earlier, that we as a participants and also panelists are enjoying the talk, the show, and the talent that you have shown to us. So thank you, Prof.Jirawat, for having a wonderful program. Before I'm going to the end, I would like to once again thank you, our participants. What I have seen here when I go over the participant, you will see that several surgeons from Myanmar joining us, Prof. Tun U, the honorary member of Royal College of Surgeons of Thailand, and also San Sanwin, and several friends from Myanmar joining. I think colorectal has been very much in the interest of everyone. We also have several friends from Philippines, friends from Cambodia, and from Iqbal from Indonesia. So, and several more joining us. When we started, we thought that it should be good for us to run in Thai local languages, but after having a lot of several requests for having an international meeting, so thank Prof. Jirawat and teams for initiating and turning the last webinar to be more contributing to our friends in Southeast Asia or in Asia or any place in the world. So at this point, I would like to thank Medtronics for supporting us. I would like to thank Professor Vitun and General Sudhajit for always staying with us with great support. Thank TTTEP, wonderful job. Songpon, now I can see your nice talent work, and also Prapon. I have heard a lot from several one, but today is my opportunity to enjoy your show, your operation very much. I think your video has been inspiring several surgeons here try to start and learn how to get into the laparoscopic colorectal cancer surgery. So with this, I think less laparoscopic endoscopic surgeon of Thailand would be going on with several activity. So please join us, stay with us. Last, I would again to thank Prof. Junji for coming, giving us a very powerful, I would say, your presence is very rewarding to us. So hopefully we will soon having Prof. Kim with us in person here in Bangkok, in Chulalongkorn, or in Thailand, because hopefully we will do that. And also thanks everyone for joining, and stay safe. be healthy, and we'll do more and more activity together. Thank you for all contribution. Thank you.
Thank you, Dr. Suthep. As our honor, can we have a group picture again with Dr. Junji Kim before we end the session or before we having a feedback form? Can we have a
Yes.
group picture again, please, Dr. Junji Kim?
Yes, absolutely. It's our honor to have a photo with all the panelists and Prof. Junji Kim. I think we are ready. Kun Chirasamon, please.
One more time. Thank you for our panelists and our speaker. Before we end the session, we would greatly appreciate if you kindly give us some feedback for the next improvement. So we have a short polling for the feedback that could you kindly give us for the feedbacks. Thank you.
Kamsamida. Thank you very much. ขอบคุณครับ
ขอบคุณค่ะท่านอาจารย์และสปีกเกอร์และ panelist ทุกท่านนะคะท่าน participant คะรบกวนwould you please fill out the feedback form or the polling in front of your screen. Thank you everyone for your attention. For attendee, if you would like to propose the next interested topic, you can put in the Q&A type by a Q&A chat box. Yeah, if you have any recommendation or there are other interested topic that you would like to propose, yeah, please kindly put in the Q&A chat box. Thank you.
How's Korea? Oppa, everything's good?
You look very good.
Yeah, hopefully we, Korea and Thailand, Les and K-cells will be connected soon. Hopefully we are in the trial period of doing some workshop in Kadawa with the K-cells, probably the colorectal team from Korea too. So soon we will establish the workshop together.
Yeah. As president of ELSA, your period is pandemic period. I think.
No, thank you. Thank you for your support. Anyway,
active Suthep udong strength up.
Excellent, thank you.
It's not good for you, yeah.
No, actually, Prof, it's good for me because we can do several activity together. Otherwise, we have to travel, and then you may have to choose 1 or 2 a month. That you cannot do more than that. But right now, you can have even 2 or 3 a day for the webinar. So I think this is also the I think the good side of the pandemic. But anyway, what I would like to say now, as one of the member of the Thai society, is that thanks Korea for giving us the lessons that you have done to control the infection. We have learned from each other, but mostly we learn from Korea. That's the tools that we are doing now. That's why we are at this point. Yeah, thanks very much. So I think there's a good sign on the pandemic too. But anyway, it's different. It's different, totally different.
So you open a new era.
Not actually. I think probably the COVID-19 has opened the new era of the communication or the academic activity. So, but anyway, soon for the didactics or the video we can do by a webinar, but soon we would trying to do the tele-mentoring from overseas to our academic lab. So, because I think the skill also part of the success in doing a very beautiful procedure, and also very very safe procedure. So we are proud to have you with us, and you should, yeah, as I mentioned that you have so many boys and girls here in Thailand.
Okay. Have a good
Okay.
good evening. Bye bye.
Take care, Prof. Yeah. Bye bye. Take care. Yeah. We'll see you soon. Bye.
Bye. Yeah.
อาจารย์ค่ะเราทำโพลครบแล้วจะขออนุญาตปิดเลยนะคะขอบพระคุณอาจารย์สุเทพค่ะ
ขอบคุณมากขอบคุณสมพลขอบคุณฮะ Prof. Junji. Okay, I want to leave this.